To start with the arrhythmia, change slide please. To start by arrhythmia, we should know small idea about what the electrical system of the heart. What is the electrical system of the heart? Electrical system of the heart starts from the SA node, which is the site of electrical impulse generation or pacemaker of the heart, and travel through the atria, and from the atria there will be a small delay at the AV node, and from the AV node there will be the electrical impulse transmitted through the bundle of His and divided into left and right bundle branch, and then distributed through the myocardium through the Purkinje fibers. Next please. So cardiac arrhythmia is the disturbance of the electrical rhythm of the heart. Any disturbance of the normal physiological electrical rhythm is called a cardiac arrhythmia. Arrhythmia might occur in structural heart disease or in a healthy heart. When the heart rate more than 90 is called tachycardia, and when the heart rate less than 60 it's termed bradycardia. What about the mechanism of tachycardia? Why tachycardia occurred? Next please. Tachycardia occurred as a result of first, increased automaticity, second, re-entry, third, triggered activity, while the bradycardia occur as a result of reduced automaticity and blocked or abnormal slow conduction, example IV block. Next please. Classification of arrhythmia. Arrhythmia can be simply classified into the shape according to the shape of QRS complex. If the shape of the QRS complex is narrow, the QRS complex is called supraventricular arrhythmia. If the shape of the QRS complex are wide and bizarre, it's called ventricular arrhythmia. Sometimes supraventricular arrhythmia even cause wide QRS complex in some situation. For example, when there is left or right bundle branch block, and when there is accessory conduction. Accessory conduction, that is conduction of the impulse from the atria to the ventricle through a bundle other than AV bundle and bundle of His, like occurred in WPW syndrome. Next please. When arrhythmia occurs, how the patient present? The patient present as a fluttering as a complaint of fluttering in the chest, or racing of the heartbeat, slow heartbeat, or chest pain, shortness of breath, lightheadedness, dizziness, fainting, polyuria. All of these symptoms can be the presenting symptom of cardiac dysarrhythmias. Next please. Now we come to a term, sinus rhythm. The normal physiology, the rhythm change during the inspiration and expiration, and when there is an increase in the inspiration and decrease in the expiration. This occurs especially in children. But in sinus arrhythmias, there is the change in the heart rate during the inspiration occur especially in patients with autonomic neuropathy. Another form of normal physiological alteration is sinus bradycardia. It occurs especially in athletic, high-trained patients and also occur in the sleep. But sinus bradycardia can occur in other pathological situations like myocardial infarction, sinus node dysfunction, when there is sick sinus syndrome, and the patient occur especially in the elderly when there's fibrosis of the sinus node, and present as alternating rhythm between tachycardia and the bradycardia. It is called tachy-brady syndrome. Also, sinus bradycardia occur in hypothyroidism, in hypothermia, cholestatic jaundice, when there is normal heart but there is a bradycardia, and also sinus bradycardia occur in situation when there is increase in intracranial pressure, and as a side effect of drugs like beta blocker, calcium channel blocker, and anti-arrhythmic drugs. A treatment, it need no treatment. Sinus bradycardia and sinus arrhythmia need no treatment if asymptomatic. Sinus tachycardia, change please. Sinus tachycardia, it occurs as a physiological or pathological. Physiological, everybody when there is an excitement, tachycardia occur. In fear situation, tachycardia occur. In stressful situation, tachycardia occurs. In exercise, tachycardia occurs. But sometimes there is pathological tachycardia. In a normal physiology, the upper limit of normal heart can be rate of normal heart rate for sinus tachycardia is thought to be 220 beat per minute minus the age. If an individual has age of 50 years, so 22 minus 50 is 170. Is the upper limit the heart can produce per minute is 170 beat per minute. So sinus tachycardia can be caused by anxiety, fever, anemia, thyrotoxicosis, pheochromocytoma, pregnancy, heart failure, and use of symptomatic drugs like beta agonists like Ventolin and butadiene. Treatment: if asymptomatic, no need treatment. If symptomatic, treatment depends on the underlying cause. Is to treat the underlying cause. For example, if the patient have fever and tachycardia, it should treat the fever. Fever and anemia, you should treat and correct the anemia. Tachycardia and toxicosis, you should treat the thyrotoxicosis. But also treatment depends on the onset and hemodynamic status. For example, if tachycardia causes hemodynamic disturbance, it should be treated urgently. Okay, next slide. Now we talk about atrial rhythm. Atrial rhythm is a form of supraventricular rhythm, that is, the rhythm that occurs above the level of ventricle. Atrial rhythm, when the generation of the rhythm occurs not from the SA node, but from the atrial pacemaker cell. So the atrial rhythm occurs in the form of either atrial ectopic beat, which is called atrial extrasystole, premature beat, and it have no symptom, or only sensation of missed beat or abnormally strong beat. The ECG shows the premature but otherwise normal QRS complex. If visible, the preceding P wave has different morphology. The treatment: to avoid coffee, tea, and stress, and if significant, may use beta blocker. Next slide. Next, atrial tachycardia. Atrial tachycardia caused by SA node disease. That is, when the SA node is defective and cannot generate automaticity, so the atrial myocardium will take over the automaticity and generate the heart rate. And also atrial tachycardia occurred as a result of digoxin toxicity, but to produce neurocomplex tachycardia with abnormal P wave morphology. Also treatment with rate control with beta blocker, class 1 or 3 anti-arrhythmic drugs. And if not controlled by medication, we resort for catheter APS, electrophysiological study, and catheter ablation. What is the APS and catheter ablation? Is to do cardiac catheterization and produce stimulate, and by the use of catheter we produce controlled stimulation of the parts of the myocardium, and until we reach the arrays that produce an increased automaticity, as we state in the mechanism of tachycardia or triggered activity, and ablate these arrays by the use of radio frequency wave. Next, please. Sometimes we have atrial flutter. Atrial flutter occurs due to a large re-entry circuit, usually within the right atrium, encircling the tricuspid annulus. Atrial flutter is a form of supraventricular tachycardia, and atrial rate is approximately about 300 beats per minute, and is usually associated with 2 to 1, 3 to 1, or 4 to 1 AV block. The ECG shows saw-toothed flutter waves. What is the 2 to 1, 3 to 1, 4 to 1 AV block? As we state previously, that the AV node the myocardium cannot tolerate there is a maximum limit for the work of the ventricle, which is the 220 minus the age. So if the atria produce a rate at approximately 300 beats per minute, the ventricle cannot outstand this high rate. So in order to compensate, there should be part of the atrial impulses cannot blocked in half the way in the AV node and cannot be generated and can transmitted to the ventricle. So maybe for every 2 atrial rate, the 1 blocked, or even 3 atrial rate, 1 blocked, or 4 atrial rate, 1 blocked. This is the 2 to 1 block, 3 to 1 block, 4 to 1 AV block. That is a block of some atrial rate at the level of the AV node in order for the ventricle to compensate for the high atrial rate. Next, please. Management. First of all, we do maneuver that increase vagal activity and reduce adrenergic activity. Which is the maneuver that increase vagal activity? Is carotid sinus pressure, because in the carotid sinus there is nerve fibers of the vagus nerve. When stimulated, may produce negative chronotropic stimulation for the heart, or cardio-inhibitory response. And so carotid sinus pressure, by doing massage over the carotid sinuses below the angle of the jaw and the neck, or by infusing intravenous adenosine, may help establish the diagnosis and the treatment in acute situation. Second, treatment for chronic cases by use of digoxin, beta blocker, verapamil. All of these produce a rate control for rapid atrial rate and can be used to control the ventricular rate. Direct current DC cardioversion by using by using intravenous amiodarone. This is reserved for acute situation when there is a need to produce a cardioversion. Cardioversion means restoring the normal heart rate. As we said that in atrial flutter, the impulse generated through the level of atrial myocardium, while the normal physiology is that impulse to be generated through the SA node. By using direct cardioversion, we produce a shift from the atrial myocardium to the SA node, and so to return to normal physiology by the use of DC cardioversion. This is reserved for a situation when there is structural heart disease or the need for restoration of normal rhythm as fast as possible, or a situation when there is hemodynamic compromise triggered by the tachycardia. For beta blocker, amiodarone also can be used to prevent a recurrent episode of atrial flutter. And finally, when the medical therapy fails, catheter ablation offers 90% chance of complete cure. Next slide, we talk about atrial fibrillation. Atrial fibrillation is the most common sustained cardiac arrhythmia, with overall prevalence of 0.5%. The prevalence rises with the age. Atrial fibrillation occurs to multiple re-entry circuit looping around the atria irregularly and an irregular pulse. The ECG is irregular QRS complexes. There are no P waves. It is different from atrial flutter. In the atrial flutter, we see saw-toothed wave, P wave, but in atrial fibrillation, there is only fibrillatory wave or no P wave. After the end of this lecture, I hope from you to resort to take the title of the subject in the lecture, for example, atrial tachycardia, atrial extrasystole, atrial fibrillation, atrial flutter, and go to the Google Images or even to ECG book and to see the picture of the ECG in any subject we talk about. So, atrial fibrillation can be classified into paroxysmal, self-terminated, that is self-terminated within 7 days, persistent, lasts more than 7 days, permanent, if not terminated, or relapse within 24 hours of cardioversion, and also classified into Lewin AF, in which the absence of structural heart disease. Next slide, please. What is the risk of AF? AF, if permanent, can cause structural remodeling within and atrial fibrosis and dilation that further predispose to chronicity of AF. AF is often completely asymptomatic. Sometimes it produces palpitation, breathlessness, fatigue, and feeling of racing heart. In patients with poor ventricular function or valve disease, it may precipitate or aggravate cardiac failure. So, AF, if occurred in a patient who have heart failure or who have structural heart disease or valve disease, it may produce acute pulmonary edema. A fall in blood pressure may cause lightheadedness triggered by AF, and chest pain may occur with the underlying coronary disease. If the patient have compensated chronic ischemic heart disease and AF occurred, it may produce a precipitation of chest pain. AF is associated with significant morbidity and twofold increase in mortality. Why? Because it may predispose to risk of thromboembolism thrombus formation within the atria and embolization to the brain or to the kidney or to the limb. Why AF occurs? Next slide, please. Common causes of atrial fibrillation. First of all, coronary artery disease, valvular heart disease, hypertension, SA node disease, hyperthyroidism, alcohol, cardiomyopathy, congenital heart disease, chest infection, pulmonary embolism, pericardial disease, and sometimes idiopathic. All these situations may cause AF. So, if AF occurred, how we can manage it? Next slide. First of all, assessment of the patient with the newly diagnosed AF include a full history, physical examination, 12-lead ECG, echo, thyroid function. The goal of treatment to restore sinus rhythm, if possible, prevent a recurrent episode of AF, and minimize the risk of thromboembolism. First of all, we talk about paroxysmal atrial fibrillation. Next slide. It not necessarily require treatment, but beta blocker are normally used. First of all, it not necessarily require treatment in some situations that we talk about it in the following chapter, in the following slides. But beta blocker are normally used. Beta blocker reduce the ectopic firing that normally initiate AF. And sometimes we use class A1C drugs such as propafenone or flecainide are also effective at preventing the episode, but should not be given to a patient with structural heart disease. Amiodarone is the most effective agent for preventing AF, but its side effects restrict its use to the patient. Amiodarone is a highly effective drug, but have numerous and significant side effects, so it's not almost always used. Digoxin and verapamil are not effective drugs for preventing paroxysms of AF. If no response because of side effect of drug, we can resort for cardiac ablation, and ablation prevent AF in approximately 70% of patients. Complications are small risk of embolic stroke or cardiac tamponade. This is the complication of cardiac ablation. For this reason, it resort as a final solution for treatment of paroxysmal AF. While persistent and permanent AF, there are two options for treating a persistent AF. Next slide, please. First of all, a rhythm control, attempting to restore and maintain sinus rhythm. Rate control, accepting that the AF will be permanent, and we do rate control and assess the risk of embolic phenomena. But if the risk of thromboembolism is high, we use anticoagulant. We prescribe anticoagulant to reduce and to prevent the embolic complication. A rhythm control can be achieved either, next slide, by a rhythm control and attempt to restore sinus rhythm. If AF, what is the indication for rhythm control? If the AF have been present for less than 3 months, if the patient is young, and no important structural heart disease. Next slide. How we do rhythm control? By immediate DC cardioversion using low voltage after the administration of intravenous heparin if appropriate, if the AF have been present for less than 48 hours. If the AF is present for more than 48 hours, we should use anticoagulant for 3 to 4 weeks and then schedule the patient for DC cardioversion. Second option is chemical cardioversion. It's performed with a drug such as amiodarone, dronidarone, procainamide, dofetilide, ibutylide, propafenone, flecainide. In other situations, when the AF is more than 48 hours, DC cardioversion, as we said, is deferred until the patient has been established on warfarin with INR more than 2 for a minimum for 4 weeks. 3. Anticoagulation should be maintained for at least 3 months following successful cardioversion. Concomitant therapy with amiodarone and beta blocker may reduce the risk of recurrence. Finally, catheter ablation by use of radiofrequency ablation or surgically through the Maze procedure, but it is less effective treatment for persistent AF than paroxysmal AF. Next slide. Sometimes we use rate control rather than a rhythm control, especially if the sinus rhythm cannot be restored. The treatment should be directed at maintaining an appropriate heart rate by the use of digoxin, beta blocker, rate-limiting calcium antagonists such as verapamil or diltiazem, or use of catheter ablation with a permanent pacemaker implanted beforehand. This is known as pace and ablate strategy. Next slide. In atrial fibrillation, there is a huge risk of morbidity and mortality. This is because risk of thromboembolism. Because of loss of atrial contraction and left atrial dilation will cause stasis of the blood in the left atrium and may lead to thrombus formation in the left atrial appendages. This is predispose the patient to stroke and other form of systemic embolization. So, if the patient have high risk of thromboembolism, we should administer anticoagulant in the form of warfarin with target INR 2 to 3 to reduce the risk of stroke by two-thirds. Also, aspirin have been used to reduce the risk of stroke by only 1/5. Echocardiography is a valuable risk stratification. How we know that the patient have high risk of thromboembolism and we should prescribe anticoagulant for him, or low risk of thromboembolism and we should not use warfarin but use aspirin instead for him? By the use of CHA2-VASC score. What is the CHA2-VASC score? Next slide. CHA2-VASC score is to ask the patient whether he has congestive heart failure, hypertension, or age more than 75, or by history he have diabetes, or prior stroke, or thromboembolism, or even have vascular disease like peripheral artery disease, or his age 65 to 74 years, or its gender, and give 1 to 2 for every one parameter as in this table. If the chart VASC, next slide, if the chart VASC score 2 or more, we should give anticoagulation for him. If the chart VASC 1, so he has low risk, moderate risk, and to discuss this with the patient whether the use of aspirin or warfarin. Or if the chart VASC score is 0, so the patient have low risk of thromboembolism, and so it's not the aspirin anticoagulant is not needed, only can be managed with aspirin daily. Okay, next slide. هذا فد الكويز لكم بعدين اذا تقدرون تحلوه. next slide. هسه احنا بقعنا من السوبرا فنتيكولار تكارديا، خلصنا من الاتريا تكارديا، حكينا الاتريا فلتر، حكينا الاتريا فيبريليشن. هسه نجي بعد الاس في تي او سوبرا فنتيكولار تكارديا. هو احنا اكو يصير عندكم مس اندرستاندينج، اكو عندنا السوبرا فنتريكولار تاكي اريثمياز اللي تشمل اتريال tachycardia, atrial flutter, atrial fibrillation, and supraventricular tachycardia. So, supraventricular tachycardia, SVT, is a part of a broad term which is supraventricular tachyarrhythmias. So, supraventricular tachycardia is a narrow QRS complex. And when the atrioventricular nodal re-entry tachycardia with a rhythm between 120 to 240. This is due to re-entry in a circuiting involving the AV node, and it is two right atrial input pathway, a fast pathway and a slow pathway. It tends to occur in the heart that otherwise normal. An episode may last from a few seconds to many hours. SVT or AV and RT, it is the same relatively. Occur when the re-entry occur within the AV node or its branches. So re-entry occur at that site. Because the re-entry occur in the AV node, so it will produce a neuro QRS complex, and its level is above the level of the ventricle. It's usually, the SVT usually affects a normal heart, but may occur in abnormal heart like ASD. And a fast heartbeat may lead the patient feel faint or breathless. So clinical presentation of SVT is fainting maybe, or maybe shortness of breath, chest pain, or even polyuria. The ECG show tachycardia with normal QRS complex, that is neuro QRS complex. next slide. هذا سلايد راح تشوفونه هو ال SVT. هذا SVT لما تشوفوه بالemergency department والبيشنت عنده palpitation or fainting or chest pain نشخص الحالة SVT. next. شلون المانجمنت مالتها؟ المانجمنت قلنا increase vagal tone by doing cardiac sinus pressure or massage or valsalva maneuver. إذا ما فادت next step هي intravenous adenosine or verapamil. Suitable alternative drugs include beta blocker or flecainide. If there is hemodynamic compromise, tachycardia associated with hypotension or shock, a DC cardioversion should be administered. If the episodes are frequent, disabling, prophylactic oral therapy with beta blocker or verapamil may be indicated. And finally, catheter ablation offers high chance of complete cure and is usually reserved for when the medical therapy is not beneficial. Next slide. Wolff-Parkinson-White syndrome. Wolff-Parkinson-White syndrome, in this condition, an abnormal band of conducting tissue connect the atria and ventricle, known as the accessory pathway. Normal band of conducting tissue هي ال AV node. ال AV node and bundle of His. Sometimes there is another band other than bundle of His connect the atria to ventricle. It's called the accessory pathway. 50% of concealed accessory pathway does not alter the appearance of ECG in rhythm. 50% of condition takes place partly through the AV node and partly through the accessory pathway. So it will produce short PR interval and a slurring of the QRS complex called delta wave, known as Wolff-Parkinson-White syndrome. The ECG appearance of this tachycardia may be indistinguishable from AV nodal re-entry tachycardia. So, Wolff-Parkinson-White syndrome, when there is accessory pathway of conduction other than bundle of his, conduct the atria to ventricle. And when the 50% of conduction take place partly through the AV node and partly through the accessory pathway, it will produce short PR interval with a slurring of the QRS complex called delta wave. And when you see short PR interval and the slurring of the upstroke of the QRS complex, it's called Wolff-Parkinson-White syndrome. And if this rate occurs fastly, more than 100 beats per minute, it is called AVNRT. Next slide, please. It should be treated as emergency, usually with DC cardioversion. If atrial fibrillation occurs, it may produce dangerously rapid ventricular rate because the accessory pathway lacks the rate limiting the properties of the AV node. Prophylactic anti-arrhythmic drugs such as flecainide, propafenone, amiodarone can also be used. Catheter ablation is the first-line treatment in symptomatic patients, as is nearly always curative. Digoxin and verapamil shorten the refractory period of the accessory pathway and should be avoided. So, if you see in the resting ECG a short PR interval and slurring of the upstroke of the QRS complex, digoxin and verapamil should not be given to the patient. Instead, we use other antiarrhythmic drugs such as flecainide, propafenone, or amiodarone. Next slide, please. Now we finish the supraventricular arrhythmia. Now we talk about the ventricular tachyarrhythmias. Ventricular tachyarrhythmias ventricular ectopic occur in the form of either ventricular ectopic beat, extrasystole, or premature beat. The difference of ventricular ectopic beat from the atrial ectopic beat is that the ventricular ectopic beats are broad, bizarre, while the atrial ectopic beats are narrow, while the ventricular are broad. The complex may be unifocal, the same shape, or multifocal, have multiple shapes, and may be couplet, 2 successive ventricular ectopic, or a triplet, 3 successive ventricular ectopic, or bigeminy. Bigeminy is that the alternating between the normal and ectopic, in the same ECG. Ectopic beat produce a low stroke volume because LV contraction occurs before the filling is complete. The pulse therefore irregular with weak or missed beat. The patient usually asymptomatic but may complain of an irregular heartbeat, missed beat, or abnormally strong beat. Next slide. Ventricular ectopic beat in otherwise healthy subject increase with the age, disappear with exercise. A treatment is not necessary unless the patient is highly symptomatic, in which case beta blocker may be used. Investigations such as echo, looking for structural heart disease, and exercise stress tests to detect occult underlying ischemic heart disease. Next, please. This slide demonstrates the difference between the ventricular ectopic and atrial ectopic beat. Next slide. But if the ventricular ectopic beat associated with a structural heart disease, for example an acute MI, persistent, frequent, more than 10 per hour ventricular ectopic beat in a patient who have survived acute phase of MI indicate a poor long-term outcome. Other than beta blocker, antiarrhythmic drugs do not improve morbidity and mortality, and even may worsen the prognosis. A treatment should be directed at the underlying condition. So, next slide. Now we talk about ventricular tachycardia. Ventricular tachycardia is a common cause of VT because ventricular tachycardia is termed VT. The common causes include most of the causes of ventricular tachycardia are serious causes. For example, acute MI, cardiomyopathy. Chronic ischemic heart disease, particularly when it's associated with a ventricular aneurysm or poor LV function. It's caused by abnormal automaticity or triggered by re-entry within the myocardium. Patient may complain of palpitation or symptom of low cardiac output such as dizziness, dyspnea, or syncope. The ECG shows tachycardia with a broad abnormal QRS complex with a rate of more than 120 per minute. VT may be difficult to distinguish from SVT with bundle branch block or WPW syndrome. Next slide. هذا الشكل مال ال VT. Wide QRS complex, rate more than 100. Next slide. Sometimes there is a slow VT. slow VT هذا اللي شفناه بالسلايد السابق. slow VT يعني الريت إذا انتبهنا على السلايد السابق الريت أقل من 100 لكن ال QRS complex shape are bizarre and wide. Slow VT at a rate only slightly above the sinus rate and below 120. These episodes often reflect reperfusion of the N5 territory. It occurred post-MI, when post-PCI, post-thrombolytic, and may be a good sign of reperfusion. They are usually self-limiting and asymptomatic and do not require treatment. Normal heart VT when ventricular tachycardia occur in the setting of no structural heart disease, usually because of abnormal automaticity in the right ventricular outflow tract or one of the particles of the left bundle branch. The prognosis is good and catheter ablation can be curative. Now, next slide, we talk about the management of VT. VT is almost always emergency situation and is a life-threatening condition, so it should be treated urgently by synchronized DC cardioversion if systolic blood pressure less than 90. If systolic blood pressure more than 90, we can use intravenous amiodarone by giving a bolus followed by a continuous infusion. Intravenous lidocaine can be used but may depress LV function, causing hypotension or acute heart failure. In case of VT, almost always you should look for the serum potassium, magnesium, acidosis, hypoxemia, and should be corrected. Finally, beta blocker is beneficial in the treatment of VT. In addition to class 1C antiarrhythmic drugs should not be used for prevention of VT in patients with ischemic heart disease. In patients with high risk of arrhythmic death, example those with poor left ventricular function or where VT associated with hemodynamic compromise, the use of implantable cardioverter defibrillator is recommended. So, if VT occurs and the patient has structural heart disease or heart failure, it is necessary for the patient to have ICD. ICD is to prevent the future development of VT while the patient at home or outside the hospital. Next slide. Feature, as we said before, the differential diagnosis of a broad complex tachycardia may be ventricular tachycardia or supraventricular tachycardia with bundle branch or WPW. So, what is the feature in favor of ventricular tachycardia and differential diagnosis of broad complex tachycardia؟ يعني شنو الأشياء اللي تفرق لك أنه هذا المريض عنده VT ومو عنده SVT with bundle branch block or SVT with WPW؟ أولا إذا عنده history of MI هذا يمشي ويا VT. ثانيا إذا عنده AV dissociation يعني أكو difference بين ال A node بين ال A wave وبين ال QRS complex، هذا باثوجنومونيك أنه المريض عنده VT. يعني إذا ال QRS مو كل QRS complex مسبوق بأي ويف. ثالثا إذا عنده capture fusion beat هم كذلك هذا معناها المريض عنده VT. شنو capture fusion beat؟ capture fusion beat لما نشوف ventricular ectopic بالاي سي جي مال المريض ومنه وبينه وقبله وبعده normal ectopic normal beat. لما نشوف المريض عنده extreme left axis division، احنا مثل ما نعرف الاي سي جي لما نقرا الاي سي جي لازم نقرا الاكسس مالته، هل هو رايت اكسس نورمال اكسس ليفت اكسس. اذا المريض عنده اكستريم ليفت اكسس ديفيجن يعني المريض عنده وعنده برود كومبلكس تكارديا يعني معناها برود كومبلكس تكارديا ديو تو في تي. اذا لما نشوف السايز مال الكيورس كومبلكس فيري برود اكثر من 140 هذا يمشي ويانا ويا الفي تي. اذا سوينا للمريض كاراتيد ساينس مساج لو انطيناه ادينوسين وما استجاب يعني ما صار ريدكشن بالريت همات المريض عنده في تي. next slide. another form of VT نسميها البوليمورفيك VT أو torsades depointes or ventricular tachycardia. The ECG in this condition show rapid irregular complexes that oscillate from the upright to an inverted position and then twist around the baseline as the mean QRS axis change. What is this? This form that in patient with polymorphic VT or torsades depointes مرة نشوف المين axis upward مرة نشوف المين axis downward كل سنة نشوف الاكسس shift or change مال QRS complex. هذه تعني أنه المريض عنده torsades depointes. هذه شنو الخطورة مال torsades depointes؟ أنه كان degenerate to ventricular fibrillation. ثاني شيء significant بيها during period of sinus rhythm the ECG will usually show prolonged QT interval وهي هاي more common in women and often triggered by a combination of etiological factor. شنو هي يعني هذه الكونديشن بيها specific trigger اللي إذا أنت صلحتها ممكن المريض يصير زين. شنو هي؟ أولا QT prolonged medication. بعض الأحيان أكو medication يسوي QT prolongation راح نحكي عليها بعد شوية. For example tricyclic antidepressant. أو بعض الأحيان المريض عنده hypokalaemia أو hypomagnesemia أو hypocalcemia، فإذا انطيت المريض بوتاسيوم كالسيوم مغنيسيوم ممكن يتعالج وتروح من عنده هاي الحالة. Next slide. هسه قلنا راح نحكي على causes of long QT interval and torsades depointes. bradycardia electrolyte disturbance hypokalemia قلنا hypomagnesemia hypocalcemia. ذني إذا المريض شفت عنده twisting axis يعني polymorphic VT وشفت دزيت السيرم بوتاسيوم مغنيسيوم كالسيوم ولقيتهن لو صلحتهن راح تتعالج الكونديشن. بعض الأحيان ناخذ من عنده هيستوري المريض شوفه هل هو ياخذ اريثرومايسين ياخذ كلوروبروبامايزين اللي هو انتي سايكوتيك ميديكيشن ياخذ اميتريبتيلين اللي هو انتي ديبريسنت ميديكيشن امايدارون بعض الأحيان يسببها سوتالول ديسوبارامايد. بعض الأحيان congenital long QT syndrome اللي هو الجين ميوتيشن يصير بالجين affecting potassium channel will lead to a long QT syndrome ونقسمها إلى long QT 1 2 3 4 وكل وحدة بها specific channel affected أو specific gene affected sorry. Next slide. Congenital long QT syndrome are family of genetic disorder. The treatment should be directed at the underlying cause. Intravenous magnesium should be given to all cases. Sometimes we use atrial pacing. Intravenous isoprenaline is a reasonable alternative to pacing. Sometimes beta blockers are effective in preventing syncope in patients with congenital long QT syndrome. Next slide. هسه احنا خلصنا من الVT، نحكي على SA node disease or sick sinus syndrome. Sick sinus syndrome occur at any age, but is most common in elderly people when there is fibrosis, degenerative changes, or ischemia of the SA node. It is present with palpitation, dizzy spell, or syncope due to intermittent tachycardia, bradycardia, or pulses with no atrial or ventricular activity, SA block. The treatment is by use of permanent pacemaker. Common feature of SA node disease. Next slide. It produces sinus bradycardia, SA block, sinus arrest, paroxysmal atrial tachycardia, paroxysmal AF, or sometimes AV block. هسه next slide رح نحكي على ال AV block. AV block ينقسم إلى أقسام. عندنا first degree AV block. In this condition the AV conduction is delayed, so the PR interval is prolonged. It rarely causes symptom. الهارت بلوك يتقسم إلى 3 أقسام: first degree, second degree, و third degree. الفيرست degree الكاركترستيك فيتشر مالته إنه ال PR interval is prolonged و it require no treatment. السكند degree heart block. next slide. هاي الصورة راح نشوف لنا ال normal heart rate first of all. second ال first degree AV block. ال first degree AV block قلنا بس ال PR interval is prolonged and need no treatment. ال second degree AV block characterized by drooped beat. شنو drooped beat؟ يعني أنه أكو P wave ما يجي وراها QRS complex. The third degree AV block characterized by AV dissociation. يعني there is dissociation between the atrial rate and ventricular rate. يعني ال P wave ما لها علاقة بال QRS complex. احنا normally كل P wave لازم يجي وراها QRS complex. إذا شفت الريذم بعض ال QRS وراهن P wave، بعضهن ما وراهن بعضهن ما وراهن P wave، وماكو علاقة بين الاتريال اكتيفيتي البي ويف والفنتريكولار اكتيفيتي كيو ار اس كومبلكس. هذا يسموه third degree AV block. next slide. هذا الحكي احنا شرحناه كما قبل شوية انه second degree block characterized by dropped beat or missed beat. انقسم الى قسمين: MOBIS 1 و MOBIS 2. الموبس 1 there is a progressive lengthening of successive PR interval that end in a dropped beat. This is known Winky-Bank phenomena and is usually due to impaired conduction in AV node itself. And this type of arrhythmia is a benign arrhythmia and cannot generate to complete heart block. While in MOBIS type 2 second degree AV block, the PR interval of the conducting impulse remain constant, but some P wave are not conducted. يعني أكو dropped beat or missed beat. This is usually caused by disease of his Purkinje system and carries a higher risk of asystole and complete heart block and should be treated. Next. The third degree block, when the AV conduction fail completely, the atria and ventricle beat independently. That is AV dissociation of the atria and ventricle. Complete AV block produce a slow 25 to 50 per minute regular pulse that cannon wave may be visible in the neck, and the intensity of the first heart sound varies due to loss of AV synchrony. Why heart block occur? Etiology. Next slide. Etiology of complete AV block. It's either congenital, occur in children, or acquired, idiopathic fibrosis of the SA node, MI, ischemia, inflammation, myocarditis, for example, aortic root abscess, infective endocarditis, or chronic myocarditis and sarcoidosis and Chicken's disease, and even in trauma, post-cardiac surgery, and even with the use of drugs, example, digoxin and beta blocker. Next slide. there is a condition called Stokes-Adam attack. Stokes-Adam attack is episode of ventricular asystole that complicate complete heart block or morbid type 2 second degree AV block. It occurs in a patient with SA node disease and may cause recurrent syncope or Stokes-Adam attack. شنو Stokes-Adam attacks? Typical episode characterized by sudden loss of consciousness that occur without warning and result in collapse. Next slide please. AV block complicating acute MI. لما ال AV block يصير بالMI عندنا two form of AV block يصير بالMI. إذا عندنا صار ال AV block ورا ال acute inferior MI complicated by transient AV block because of right coronary artery supply to the AV node. If the patient remains well, no treatment is required. But if symptomatic, second or third degree AV block may respond to atropine 0.6 mg IV repeated as necessary. Or if this fails, a temporary pacemaker may be inserted. In most cases, AV block will resolve within 7 to 10 days. Second or third degree AV block complicating acute anterior MI indicate extensive ventricular damage involving both bundle branch and carries a poor prognosis and may require permanent pacemaker insertion. So AV block complicating acute MI have two forms, following acute inferior and is good prognosis, and following acute anterior it indicates a poor prognosis and may need permanent pacemaker insertion. Next slide. There is a bundle branch block and hemiblock. Conduction block in the right or left bundle branch can occur as a result of many pathology including ischemic or hypertensive heart disease or cardiomyopathy. This causes delayed conduction into the LV or RV and broaden QRS complexes and produce characteristic alteration in QRS morphology. Depending on the type of bundle blocked. If the right bundle branch block next slide, can occur in healthy people, but a left bundle branch block often signifies important underlying heart disease. The combination of right bundle branch block and left anterior or posterior hemiblock, known as bifascicular block, which is significant because it may then degenerate to complete heart block. Why bundle branch block occur? Next slide. قلنا البندل برانش بلوك يصير اذا شلون نعرفه لما نشوف ال QRS complexes are wide and have specific morphology نسميها ال M-shape pattern. اذا هذا ال M-shape pattern صار بال V1 V2 V3 راح نسميه right bundle branch block. اذا صار ال M-shape pattern صار بال V5 V6 راح نسميه left bundle branch block. ليش يصير البندل branch block? Right bundle branch block occur as a normal variant, right ventricular hypertrophy or cesarean, example pulmonary embolism, congenital heart disease, ASD, coronary artery disease. Left bundle branch block يصير بالcoronary artery disease, بالhypertension, بالاortic valve disease, بالcardiomyopathies. Next slide. مثل ما تشوفون احنا البندل branch block الكوزز مال left bundle branch block most of them are serious, بينما cause of left bundle branch block most of them are serious, بينما causes of right bundle branch block are less serious. Almost always when you see a bundle branch block in the ECG, you should investigate the patient according to the causes of bundle branch block. For example, إذا شفنا عندنا المريض right bundle branch block لازم نسوي له approach to exclude structural heart disease like ASD and to exclude pulmonary embolism and pulmonary parenchymal disorder. بينما إذا شفنا المريض عنده left bundle branch block لازم should exclude ischemic heart disease, hypertension, aortic valve disease and cardiomyopathy. هسه راح نحكي على anti-arrhythmic drug therapy. Classification of anti-arrhythmic depend on effect on intracellular action potential. يقسموها إلى class 1 2 3 4. class 1 هي الممبرين stabilizing agent اللي نسميها الصوديوم channel blocker. بنقسمها further according to prolongation of action potential. يعني drug اللي تسوي لنا بلوك للصوديوم channel و prolong action potential مثل كينيدين ديسوباراميد. drug اللي يسوي لنا blocking للصوديوم channel لكن shorten action potential اللي هي الليدوكاين والنكزيليتين اللي يستخدمها بالventricular tachycardia. بين الدراج اللي بلوك للصوديوم channel وما عندها افكت بالاكشن بوتنشال مثل الفليكينايد والبروبافينون اللي يستخدمن بالاس في تي والاي اف without structural heart disease. كلاس 2 اللي هي البيتا بلوكر. كلاس 3 drugs whose main class 3 drugs whose main effect is to prolong the action potential مثل الاميدارون والسوتالول. اميدارون والسوتالول هذا اللي يستخدم بالفنتريكولار تكارديا. السوتالول وكذلك الاميدارون يستخدم بهول رينج اوف تاكي arrhythmias من السوبرافنتيكولار للاي اف للفنتريكولار. Note by some drugs مثل الديجوكسين والادينوسين have no place in this classification, while others have properties in more than one class. For example, amiodarone, which has action in all 4 classes. Other drugs, next slide, atropine اللي هو atropine sulfate اللي يستخدم في cases in treatment of cases of heart block اللي by giving 0.6 mg IV repeated to a maximum of 3 mg. إذا ما فاتت 3 ملغ بالكيسز اوف هارت بلوك، الخطوة الثانية شو نستخدم الأورسبرينالين، وإذا ما فات الأورسبرينالين يروح للتمبراري بيس ميكر. Adenosine, next slide, must be given intravenously. It's a drug of choice for treatment of supraventricular tachycardia. It produces transient AV block lasting for a few seconds. Adenosine is given as intravenous bolus, initially 3 mg over 2 seconds. If there is no response after 1 to 2 minutes, then 6 mg should be given. If necessary, after another 1 to 2 minutes, a maximum dose of 12 mg may be given. Patients should be warned that they may experience short-lived and sometimes distressing flushing, breathlessness, and chest pain. Adenosine can cause bronchospasm and should be avoided in asthmatic. Its effects are greatly potentiated by dipyridamole and inhibited by theophylline and other xanthine. And sometimes the response for adenosine gives a diagnosis for the origin of tachycardia. Next slide. For example, when you give adenosine to supraventricular tachycardia, it will lead to termination. So it terminates supraventricular tachycardia. When it is given to atrial fibrillation, atrial flutter, it will only slow the rate and produce transient AV block. While when it is given to ventricular tachycardia, it produces no effect in this patient. So use of adenosine can be for diagnostic purpose to illuminate the origin of ventricular tachycardia. Next slide. Digoxin, another anti-arrhythmic drug, a purified glycoside from European foxglove digitalis lanata. Slow conduction and prolonged refractory period in AV node. Digoxin is largely excreted by the kidneys, and the maintenance dose should be reduced in children, older people, and those with renal impairment. It is widely distributed and has long half-life, 36 hours, so that effect may persist for several days after the last dose. Digoxin is used in case for rate control, in case of AF with heart failure, or in case of AF with mitral stenosis or mitral valve disease. Next slide. Therapeutic procedure: external defibrillator and cardioversion. This will interrupt the arrhythmia and produce a brief period of assystoly that's usually followed by resumption of sinus rhythm. Defibrillator deliver a DC high energy direct current short duration shock via two metal paddle coated with conductive jelly or gel pad positioned over the upper right sternal edge and the apex. Molar unit delivered biphasic shock during which the shock polarity is reversed mid-shock, halfway. This produces a total shock energy required to depolarize the heart. Next slide. Electrical cardioversion. This is the termination of organized rhythm, such as AF or RVT, with a synchronized shock, usually under general anesthesia. The shock is delivered immediately after detection of R wave. High energy shock may cause chest wall pain post-procedure, so if there is no urgency, it is appropriate to begin with a lower amplitude shock like 50 joule, going to a larger shock if necessary. Larger shock is 160 or 150 or even 300 can be given to a more dangerous rhythm like VF. Next slide. Catheter ablation. The technique has revolutionized the management of many arrhythmias and is now treatment of choice for AV and RT and AV reentrant accessory pathway tachycardia, where it's curative in 90% of cases. Also, it's used in case of atrial flutter and fibrillation when the medical therapy failed to control the condition. And finally, next slide, pacemaker. We talk about the pacemaker. We have a permanent pacemaker and temporary pacemaker. Permanent pacemaker is used when there is a need for when there is heart block and that cannot be, and the cause cannot be restored or corrected, and the cause is not transient. Then a temporary pacemaker is used for heart block when the cause is transient. For example, for acute heart block following acute inferior MI, when there is no benefit from medical therapy, we can use temporary pacemaker for 7 to 10 days, and thereafter the condition will respond and will remove the pacemaker. While implantable cardioverter defibrillator, it is used for primary prevention of ventricular tachycardia after MI if the LV ejection fraction is than 30, mild moderate heart failure on optimal drug with LV ejection less than 35, and secondary prevention of patients who have survived a VF or VT or cardiac arrest not due to transient or reversible cause, and VT with hemodynamic compromise or significant LV impairment. احنا الاي سي دي شو وقت نحطه يا اما المريض هو اساسا صار عنده في اف في تي والكوز مو ترانزيت وريفرسبل مثل ما اكيوت ام اي، او اذا هو عنده في تي وعنده هارت فيلير وياه، هذا نوصي انه نقول له لازم تخليه اي سي دي. بعض الاحيان المريض هو ما صار عنده في تي برايمري بريفنشن، شو وقت نحط له اي سي دي؟ اذا بعد الام اي ال في ايجكشن فراكشن اقل من 30، لو المريض عنده هارت فيلير والايجكشن فراكشن مالته اقل من 35 او ماكسيمال انتي فيلير ميديكيشن، هاي الانديكيشن مالته. بعض الاحيان يستخدم السي ار تي. نكست سلايد. السي ار تي هو synchronized resynchronization cardiac resynchronization therapy. هذا improves symptom and quality of life and reduce mortality in patients with moderate severe symptomatic heart failure who are in sinus rhythm with left bundle branch block with LV ejection fraction أقل من 35%. هسه خلصت هاي المحاضرة. إذا أكو سؤال I welcome. هي دائما محاضرة الارrhythmia is difficult because it is new and the lecture is complex and have multiple subjects. So I recommend to review the lecture with the use of pictures for each subject from the book of ECG or from Google image. Okay, هسه اكو سؤال؟
عشتكم دكتور. لا